This morning we have two of our sub-interns who are going to be presenting interesting topics. First we have Laditi, and he's going to be talking about does primary tumor resection affect survival in oligometastatic renal cancer? And then we'll have Iain who's going to be talking about Pembro use in BCG-Unresponsive Non-Muscle-Invasive Bladder cancer, appraising the data.
All right, I'll get started. So as Dr. Kellner mentioned, my name's Folawiyo, and I'm a medical student at Yale School of Medicine and currently on my sub-I with the urology department. And today my talk will be about does cytoreductive nephrectomy affect survival in oligometastatic renal cancer? So in this presentation, I will first sort of talk about what oligometastases are and outline some of the genetic evidence for their existence. Then I'll talk about cytoreductive nephrectomy, which is the removal of a primary tumor as well as the associated kidney together in the interferon area. And then finally about cytoreductive nephrectomy in the targeted immunotherapy era. So to start, I wanted to present a case of a 59-year-old female who was found to have a 4-centimeter irregular right renal mass confined to the kidney. Biopsy revealed clear cell renal cell carcinoma, and staging CTs revealed an additional 2-centimeter mass in the left lung. This patient underwent right radical nephrectomy and resection of the lone pulmonary metastasis. At 10-year follow-up, the patient had no evidence of residual disease. So the reason I bring up a case like this, even though the patient today would definitely receive adjuvant or neoadjuvant therapy today, is because this is an example from one of the first published case reports where there was an apparent cure of a kidney cancer patient in 1963. This patient had had their primary tumor removed, and then a couple months later had their lone pulmonary metastases removed. In 1963. So, however, the earliest recorded metastastectomy is the removal of metastatic disease for renal cancer had occurred since 1939. And this brings me to the discussion of this idea of operability and inoperability. Can resection in stage 4 disease improve survival? Hogginson and Stout were two breast oncologists who in 1943 published a paper about this, and this concept has generally been applied to most solid tumor types. But in a subset of patients who tended to have better performance status and relatively low disease burden, these patients seem to do better with resection of both their primary and their metastatic disease. So that brings me to this idea of oligometastasis, which at the time wasn't a term, but will be one I will explore and discuss a little bit more shortly. So with this slide, I just wanted to talk about renal cancer treatment generally and really just focus in on stage 4 disease. So generally, across all cancer types, the later the clinical stage of disease, the more common it is for patients to get systemic therapies, and surgery tends to be more reserved for palliation, whether that be of pain, spinal compression, small bowel obstruction, etc. But in certain stage 4 renal cell cancer patients, these patients, some of them will still get upfront nephrectomy or nephrectomy at some point in their disease course for therapeutic benefit. Noticing this in renal cell carcinoma, as well as other solid tumor types, in 1995, Hellman and Wishelbaum first published about the term oligometastases, which they defined as patients who had less than 5 metastatic sites or disease limited to a single organ. However, since they first published about this, there's been an explosion of this topic in the literature, and there are a variety of definitions today. So the idea really being that there's a subset of patients on the spectrum where the more localized a patient's disease is, the more they may benefit from local therapy, to the more disseminated, the more likely they are to benefit from systemic therapy. But this group of patients over here who have who have metastatic disease but still have relatively low disease burden, these patients may benefit from a local therapy. So with this presentation, I really wanted to look at and try to answer two questions. Do patients with oligometastatic disease represent a distinct, definable group of patients in clear cell renal cell carcinoma with different outcomes? And two, are there therapeutic implications of resection on survival in this subset? So to try and answer the first question, I turned to this paper published in Cell in 2018 called Tracking Cancer Evolution Reveals Constrained Routes to Metastases. So in this, the researchers sequenced biopsies, sequenced about 800 biopsies of both primary and metastatic disease across 100 patients. And they used this information to construct genetic trees, phylogenetic driver trees from these patients, and found that in patients who had more rapid progression of their disease, they had a certain subset of mutations, increased chromosomal complexity, and decreased intratumor heterogeneity versus patients who more gradually accumulated metastases, had a more oligometastatic phenotype, had lower chromosomal complexity, and increased tumor heterogeneity because of the chance and time to accumulate mutations. One of the key results from this study was where they looked at the commonly found and overrepresented mutations in the primary and the metastatic tumors. And they found that in the metastases, the loss of the short arm of chromosome 9 and the long arm of chromosome 14 were two events that seemed to be greatly associated with the increased risk of widespread disease. These mutations tended to be subclonal in the primary tumors, suggesting that they were not strongly associated with the primary tumor progression. And then on the right over here, we have the example of two of their patients for whom they did sequencing posthumously to sort of illustrate the main difference between these two groups of patients. So in the first one, this patient unfortunately had the loss of 9p and 14q relatively early on in their disease course. And despite treatment with pazopanib and nivolumab, quickly had widespread disease versus the other patient who did not have these genetic events. And in this fish plot, you can see that they slowly accumulated other mutations. And while they did eventually have loss of 9p and 14q, this happened much later in the disease course. And this patient first slowly accumulated metastases before having these widespread metastases. Sorry. So this suggests a distinct path of tumor evolution based on the genetics of the tumors. And in their own words, that in oligometastatic patients, that these patients may be patients who could be identified early and would be more likely to benefit from resection of their disease versus other patients who, even with a relatively low tumor burden initially, would be more likely to rapidly accumulate tumors. So there are a number of other papers that look at this too, many also identifying differences in things like mRNA profiling and gene expression, and correlating that to differences in patient survival. Taken together, these data suggest that oligometastatic disease patients may be a distinct subset of patients with distinct clinical outcomes. So next, I wanted to try and tackle the question of, does resection in oligometastatic patients provide a survival benefit? So for today, I will limit my discussion to cytoreductive nephrectomy, but there is a breadth of literature on metastastectomy, the removal of metastases as well on this topic. So besides the vast number of case reports and retrospective data that existed trying to address this question, one of the first clinical trials to really look at it was the SWOG 8949 trial. The key things were that most of the patients in the study met the definitions of oligometastatic disease in that they had either only lung metastases or very few other metastases. These patients had good performance status and were viewed to be good candidates for surgery. What they found that there was a survival benefit to patients undergoing upfront nephrectomy, so nephrectomy before interferon alpha therapy, compared to patients who only had interferon alpha therapy alone. A similar trial in Europe had the same design, so pooled analysis showed the same results. So it was really at this point that the standard of care became that for patients with low metastatic disease burden, good performance status, that they undergo upfront cytoreductive nephrectomy. But this was right before targeted therapies became more widespread. So the question became, would upfront CN still be considered superior? So there are a number of retrospective studies that attempted to look at this, and this is just an example of some of the larger studies in this area. What I wanted to highlight was the Hanna paper published in 2016, where they looked at patients who had CN versus those who didn't, and in their cohort, about 90% of them underwent upfront cytoreductive nephrectomy, and they found that there was a difference in survival. However, about 10% of their patients in this cohort actually had delayed cytoreductive nephrectomy, and they noticed an even greater difference in appreciable overall survival. And that point will become important later. But the issue with a lot of these retrospective studies is that the differences in several key important prognosticators of survival, such as median age, performance status, and risk category. Patients in these studies who undergo CN were more likely to be younger, white, male, married, insured, and likely to be treated at academic institutions. And only one of these papers really addresses the question of performance status and risk category. And you can see that there are significant differences in these between those who underwent cytoreductive nephrectomy and those who didn't in these. So even after adjustment, they still show differences in survival. But unfortunately, with this type of data, you're always limited by what is collected and stored in the databases. So enter the Carmina trial in 2018, which was a randomized clinical trial that attempted to address this question. Does upfront cytoreductive nephrectomy with sunitinib, a receptor tyrosine kinase inhibitor of VEGF and platelet-derived growth factor, does cytoreductive nephrectomy improve survival in patients who are MSKCC, intermediate risk, and poor risk status disease? So they found that there are no differences in overall survival in these patients, their primary endpoint, or objective response rate and progression-free survival. So sunitinib only was non-inferior to cytoreductive nephrectomy. The Carmina, and then at a follow-up presentation in 2019 for this trial, the researchers now had a median follow-up time of 61.4 months, and they reclassified patients by the other widely accepted risk stratification score, the International Metastatic RCC Database Consortium, and found that there was no difference in overall survival in patients who had one risk factor, and longer survival if they received sunitinib only if they had two or more risk factors, demonstrating how important risk stratification is for choosing surgical patients. Importantly, when they stratified patients by the number of metastatic sites, they found that even for patients who had just one metastasis versus greater than one metastasis, there were still differences in arm A versus arm B, showing that the number of metastases were not a good measure to determine surgical candidates. So by both risk groups, sunitinib only was not inferior to sunitinib plus CN, and the number of metastatic sites was not enough to define those who were good candidates for CN relative to sunitinib only. What was, though, were patients who had delayed nephrectomy. In arm B, 40 patients received it, and they noticed a difference in survival compared to those who did not. And this is similar to the next trial I'll discuss this time. So in this trial, they wanted to compare patients who had upfront cytoreductive nephrectomy to those who underwent several cycles of sunitinib first. And what they found unfortunately, was that what they found, was that while they had poor accrual, they were only able to get 99 patients of the initial 458 they thought they would require to answer this question. They ended up doing an intention to treat analysis with these 99 patients and showed no difference in progression-free survival, but they did show a difference in overall survival between the deferred CN patients and the immediate CN patients. So they and others have used this to conclude, while in accordance with Carmina, that while upfront cytoreductive nephrectomy doesn't seem to have a survival benefit for a lot of these patients, that delayed refectomy may be a viable option for patients with oligometastatic stage 4 renal cancer. So to sort of summarize a lot of what I've talked about, several retrospective studies, even in multivariable analyses, show that there is a survival benefit to undergoing cytoreductive nephrectomy, particularly upfront cytoreductive nephrectomy. However, these studies are limited by the data collected, and there are striking differences in the patient populations between those who do undergo this and those who do not. And the best evidence we have for upfront cytoreductive nephrectomy showing no survival benefit comes from the Carmina trial, which showed that in at least those with intermediate and high-risk disease, there is no survival benefit there. However, should note that Carmina did not have candidates who were candidates for upfront surveillance strategies or had favorable risk disease. And then, of course, the start time trial suggests that there's some benefit in overall survival if deferred cytoreductive nephrectomy, at least compared to upfront cytoreductive nephrectomy, but they had several accrual issues. There are actually, going forward though, a number of trials that are addressing immunotherapy, some of the new and even better systemic therapies, such as Nordic Sun, which will be looking at delayed cytoreductive nephrectomy plus nivolumab versus nivolumab only, and CytoShrink, which will be looking at radiation plus ipilimumab and nivolumab versus patients who receive these two immunotherapies alone. And there are a number of others over the next coming years. So in oligometastatic disease, patient characteristics such as performance status, disease burden, time to diagnosis are important factors for defining who may benefit from CN. Risk stratification likely has big implications on those who will do well with surgery and those who do not. And this seems to be much more important than defining the number of metastases that a patient has on whether or not surgery may have an effect on their overall survival. So while the genetics and clinical evidence point to the existence of oligometastatic disease, the role of resection is still continuing to be defined in these patients. Could genetic profiling better help surgeons in the future classify patients, or is the clinical picture and current risk stratification enough? How does improved systemic therapies like immunotherapies change the picture on whether or not the role of cytoreductive nephrectomy, whether it be upfront or delayed, in treating these stage 4 low disease burden patients? Overall, though, I think this is an interesting case study in the evolution of scientific evidence and how we value and evaluate various forms of evidence and continue to weigh them against each other to help answer some difficult questions, such as, in this case, who will benefit from tumor resection. So to end my presentation, I'd like to leave you with a quote from Katie in 1997, where he said, "In the land of surgical oncology, cancer biology is king, case selection is queen, and technical maneuvers and alternatives of surgical approaches are the princes and princesses of the realm. Occasionally the prince or princess revolts and attempts to rule the realm, but they are always defeated by the powerful forces of the king and queen, cancer biology and careful case selection." So thank you very much for listening, and now I'll take questions.
Well, that was a great overview of a really complicated topic. I think you're right to be cautious about the idea that the extent of metastatic disease in terms of number of metastases or sites of metastases are good selection criteria. And I tend to think in my own practice that that's more helpful when selecting patients for metastasectomy, and not so helpful in selecting patients for cytoreductive nephrectomy.
Right.
I also think it's really important, as you did, to call out that the retrospective literature is really problematic, and there are so many unmeasured confounders that go into why we do cytoreductive nephrectomy and why we don't. That those are really good. It's almost certain that those we do cytoreductive nephrectomy and are going to have better overall survival. And I think those retrospective studies can't possibly account for all of those unmeasured things that confound the analysis. I do have a question for you about if you could. I was wondering I would love to hear your thoughts about why you think cytoreductive nephrectomy for an individual patient may actually improve survival. And so, like, in getting at cause. So what do you think cytoreductive nephrectomy may actually do to make people live longer?
Yeah, so I was reading about this, both in that Carmina paper, some of the things that they suggest, and some other papers, including that paper I talked about the biology of the sort of two routes of tumor evolution. And I guess a very common theory about that, and one that I tend to agree with, especially after looking at some of those biological papers, is sort of this sink of tumor heterogeneity idea, and that if you remove the primary tumor, you're sort of removing the potential or the ability for these tumors to develop some of these key mutations that seem to be linked to metastases. So if you're removing that, then ideally, hopefully you're catching these patients before these tumors are able to seed off subclones into the rest of the body and potentially able to therefore improve their survival.
Yeah, I think that makes a ton of sense. And so the follow-up question then is, why do you think, what do you think it is about deferring cytoreduction that matters?
So that question, honestly, is one I've been struggling with a little bit myself. But from what I see in the literature on some of the theories about it, I think this one I don't think I have as good of an answer on, but potentially by decreasing, I think, in particularly the metastatic populations, which tend to be a little bit more homogeneous, still, you're able to overall reduce the disease burden, and ideally these patients, the ones who respond well and don't have disease progression, it may just be that because of this, you're gonna have decreasing the overall tumor burden and then removing a large chunk of tumor, you're just gonna have better outcomes in these patients. Or it could also just be, I think, another prevailing theory is that these patients were going to do well regardless. So it's hard to say exactly whether or not the removal of the primary tumor in that case does have is the cause, I would say, of their improved survival.
I think those are really insightful points. I mean, so I clinically use systemic therapy when people are in the gray zone. You're not really sure that they're going to do well with cytoreductive nephrectomy. We use systemic therapy as a litmus test, right? And the idea is that if they have progressive disease, they go on to additional systemic therapy. So the people who you're doing a deferred cytoreductive nephrectomy in have been proven to not have rapidly progressive disease. Right. And so that population of patients is healthier. And so it may not be the fact that you're actually deferring the cytoreductive nephrectomy. It may be that you're finding out who are going to be the rapid progressors and leaving them out. So yeah, those are, I think, really impressive review of a complicated topic.
Thank you.
Fola, nice talk. A very good talk. To a follow-up question, a little bit of a harder question is I agree with you about what you said about what the idea is, why cytoreductive surgery might help. But I'll have you extrapolate that supposition to say that, this is a hard question to ask, but what would be happening in the future if your theory about cytoreductive surgery is beneficial, that harms those patients?
Sorry, Dr. Singh, I'm not sure I fully understand your question.
Yeah, it's a hard question. It just reminds me of what's happening with coronavirus. It's a similar kind of thing. If you're saying that you remove this large reservoir of tumor, and so you have less of potential mutation events that could be harmful for the patient, basically what it's saying then is that even though that patient already has metastatic disease, they're not going to die from that metastatic disease. They're going to die from a different metastatic disease that we're preventing by removing the tumor, right? Kind of like we vaccinate the population so there's less events for a large mutation to occur, a bad mutation to occur. It's kind of that idea.
Right.
Which I don't know if that's, no one knows, but I don't know if that's true, that in a patient who already has metastatic disease, you're going to benefit them by having them have not allowing them to have a different clonal metastatic disease, right? That's the extrapolation of that theory.
Oh, okay, I see. So you're saying that, but basically by removing the primary tumor, we're saying that even though they already have tumor metastases, whether or not in those patients, I guess really in those patients, if the other mutations that they've accumulated will have an effect. So, yeah, honestly, I'm generally not sure about that, and like where sort of the literature is on that.
Yeah, it's almost, I mean, it's almost, I'm just thinking about how you answer, it's almost an impossible question to answer other than some profiling. But then when you do genetic profiling, which is the ones that you would pick? It's very difficult to know.
Right.
There was a paper about almost 10 years ago in the New England Journal looking at intratumor heterogeneity and comparing it, the tumor heterogeneity in renal cell to the metastases, and there was far more heterogeneity in the tumor than in the primary tumor than people had initially, than kind of our field had initially thought. I'll put a link in the chat, but it's interesting, and it gets at that and kind of supports what Fola was saying.
Right, but that makes sense, right? Because once it's a metastases, then it's a clonal selection. So it's one of the heterogeneity tumors that got the ability to spread, and that is now clonal replication.
Right.
All right, very good job, Fola. For the sake of time, we're going to move on to our next talk. We're going to have Iain Drew, who's going to talk about Pembrolizumab use in BCG-Unresponsive Non-Muscle-Invasive Bladder Cancer, appraising the data.
So, hi all, my name is Iain Drew. I'm currently a fourth-year medical student at the Frank H. Netter School of Medicine at Quinnipiac University. Today, I will be discussing the use of pembrolizumab in BCG-unresponsive non-muscle-invasive bladder cancer. So, let's begin. So to set the stage, a 73-year-old male who recently underwent transurethral resection of bladder tumor, revealing carcinoma in situ non-muscle invasive bladder cancer. He underwent induction and maintenance intravesical BCG therapy and was found to be unresponsive. He's now refusing radical cystectomy and would like to know his other options. So as an overview of the presentation, we will begin by briefly discussing the non-muscle invasive bladder cancer risk stratification, go over the SWOG protocol, define BCG failure, define optimal trial designs for BCG unresponsive non-muscle invasive bladder cancer, review the pembrolizumab Keynote trial, assess the data and considerations relevant to it, and finally discuss future directions and opportunities. So after initial transurethral resection of all visible bladder tumor, we can determine stage and grade in addition to assessing risk factors, helping us guide risk stratification. The AUA stratifies high-risk patients as those with grade T1, any recurrent high-grade TA, high-grade TA greater than 3 centimeters or multifocal, any carcinoma in situ, any BCG failure in high-grade patients, in addition to any variant histology, any lymphovascular invasion, and any high-grade prostatic urethral involvement. So for this talk, we will focus on high-risk non-muscle invasive bladder cancer patients. Here are the current AUA guidelines for this patient population. So upon detection, we administer a 6-week course of BCG. And for those who respond, they should receive maintenance BCG for 3 years, both of which are grade B recommendations. If high-risk patients are unresponsive to BCG following 1 year of treatment, we should offer radical cystectomy, which is a grade C recommendation. Finally, if high-risk BCG unresponsive patients refuse or are unfit for cystectomy, we should offer clinical trial enrollment, offer additional intravesical therapies, or systemic pembrolizumab for patients with carcinoma in situ. So the SWOG Protocol, or Southwest Oncology Group Protocol for BCG use in high-risk non-muscle invasive bladder cancer patients, which was first reported by Dr. Donald Lamb in 2000, has become the gold standard for BCG therapy. It includes an induction period in which BCG is introduced into the bladder through a catheter and held for 6 weeks. Maintenance therapy is then initiated, which consists of BCG administered 3 times per month in increasing intervals up to 3 years. So BCG failure is such an important topic because up to 30 to 40% of patients fail BCG treatment and will then need additional therapies. BCG failure is broken down into 4 classifications, here defined by Dr. Ashish Kamat of MD Anderson Cancer Center. The first is BCG refractory, which is persistent high-grade disease at 6 months after adequate BCG treatment, in addition to any disease progression at 3 months. BCG relapsing, which is recurrence of high-grade disease after achieving a disease-free state for 6 months. BCG intolerant, which is inability to receive BCG due to toxicity. And finally, BCG unresponsive, which includes both BCG refractory and BCG relapsing. So this is the category that we will focus on, as they are considered the highest risk and should be patients included in clinical trials for new therapies. For clinical trial enrollment, we should also define adequate BCG therapy. This consists of those who received at least two courses of BCG, 5 out of 6 installations of induction, 2 out of 3 of maintenance, are within 6 months of exposure to last BCG therapy, and have high-grade TA, T1, and/or carcinoma in situ. So for studying new therapies in BCG unresponsive patients, there are 2 sets of recommendations utilized. The first is from the International Bladder Cancer Group, which recommends a complete response for carcinoma in situ or recurrence-free rate for TA tumors of at least 50% at 6 months, 30% at 12 months, and 25% at 18 months. The second is from a joint workshop from the FDA and the AUA that recommends a complete response rate of 40 to 50% at 6 months and a response rate of 30% at 18 to 24 months. So now let's review the Pembrolizumab Keynote 057 phase 2 trial. This trial's results led to FDA approval this past January. So this table is from a study published in The Lancet last week, led by Dr. Arjun. To begin, pembrolizumab is a humanized antibody that blocks the PD-1 receptor on lymphocytes, which normally prevents immune cells from destroying normal tissues as well as cancer cells, thereby allowing the immune system to target cancer cells. This was a single-arm, multi-center trial that consisted of 2 cohorts. Cohort A, which included patients with carcinoma in situ, and Cohort B for patients with high-grade TA or T1 without carcinoma in situ. Pembrolizumab was administered every 3 weeks, and patients were treated for up to 36 months. They were followed by regular cystoscopy, directed biopsies, urine cytology, and CT urography. Their primary endpoint was complete response rate. So this was defined as the absence of high-risk disease or progressive disease. And the main findings from the study were drawn from Cohort A, which included 101 patients who received at least one dose of pembrolizumab, and subsequently 96 were included in the analysis. So let's dive into the data. Here is a Kaplan-Meier curve on the left that includes all of the patients who achieved a complete response rate. Below is a time to complete response or recurrence for these patients. So we can see that 41% of the 96 patients achieved a complete response rate. As we follow these patients though, only 46% of the initial 41% remained in complete response for 12 months or longer. And at the time of data cutoff at 36 months, only 28% of the original 41% had an ongoing response. They report that 51% of the original 41% had recurrent disease after initial complete response. And finally, the median duration of complete response for those who achieved it from time of onset was 16.2 months. So Gil and Prasad, they published an editorial in JAMA Oncology with a great flowchart to visualize the data. So of the 96 patients treated with pembrolizumab, 39 had an initial complete response. If we follow down, by 12 months, 21 of the original 39, or around 50%, relapse, leaving only 18 patients, or 19% of all patients treated with pembrolizumab remaining in complete response. If we add the patients who relapsed after complete response to the patients who initially had therapeutic failure with no complete response, we see that by 12 months, 78 of the original 96 patients, or 81% total, no longer gain benefit from pembrolizumab. These patients would then need further additional therapies. If we compare this to the recommendation outlined prior, they recommend at least a 30% complete response rate at 12 months. Here we see that a measure of 19%, they fall far short. Additional findings reported were median progression-free survival, or the time from treatment initiation until disease progression or worsening, in 50% of patients, contained in their supplementary data. Additionally, they report on overall survival. So compared to the prior Kaplan-Meier curve, we see that these include all 96 patients included in the study. So we must consider that these patients also underwent additional therapies, including alternative intravesical therapies and cystectomy. The only median progression-free survival reached was median progression-free survival to invasive disease, metastatic disease, or death, which was 39.9 months, which can be seen in the center figure. Median progression-free survival to worsening of grade, stage, death, and median overall survival were not reached at the endpoint of the data. Or in other words, these measures couldn't be calculated because more than half of them did not have muscle-invasive metastatic disease or death, and more than half of them were still alive. We can also see that at 12 months, progression-free survival to worsening of grade, stage, or death was 83%. Progression-free survival to muscle-invasive disease was metastatic disease and death was 97%, and overall survival was 98%. So when considering that at 12 months, 81% of patients treated with pembrolizumab require additional therapies, we must question whether a delay in cystectomy in these patients could lead to worse outcomes. Above is a study from Jaeger et al. That found that in high-risk patients, waiting greater than 12 months reduced cancer-specific survival at 5 years to 72%, compared to 86% in those who underwent cystectomy at 4 months. When looking at 10 years out from diagnosis, in those who waited greater than 12 months for cystectomy, the cancer-specific survival dropped to 61%, from 84% in those who underwent cystectomy within 4 months. Now, a large caveat is that this is a different patient population than those studied in the Keynote trial, who had additional therapies before undergoing cystectomy. Nonetheless, it's important to consider that patients who opt for pembrolizumab and then fail treatment undergo cystectomy at later time points than undergoing immediate cystectomy upon recognition of BCG unresponsive status. We therefore must question if deferring cystectomy in these patients may lead to worse outcomes. So when looking at the Keynote trial data for those who ultimately underwent cystectomy, we can see that of the 57 initial non-responders, 51% underwent cystectomy. And of the 25 patients who initially responded but relapsed during treatment, 44% then underwent cystectomy. Added together, a total of 38 of the original 96 patients required cystectomy after pembrolizumab discontinuation, or 39% of total patients. Of those 38, we can see in the table on the right that 88% had no pathologic upstaging, but 8% progressed to muscle-invasive bladder cancer after pembrolizumab discontinuation. So considering the fact that the majority of patients did not experience disease progression, these results may be reassuring. We still must question, though, if a large segment of patients treated with pembrolizumab inevitably go through cystectomy and a meaningful portion have worse outcomes, could we be harming patients by offering pembrolizumab as an alternative treatment? Furthermore, when looking at the baseline characteristics of patients included in the trial, we can see that 96% of patients declined cystectomy, while only 3% were considered ineligible. Therefore, the vast majority of patients were actually candidates for radical cystectomy upon BCG-unresponsive status recognition. And currently, pembrolizumab therapy is approved for both those who are ineligible for cystectomy and for those who refuse cystectomy. So pembrolizumab is in essence approved for all high-risk BCG-unresponsive patients. Therefore, we must recognize that patients who may once have agreed to cystectomy may now refuse because they believe there is a less invasive and effective treatment option. Although patient autonomy and choice is an important consideration when deciding treatment, radical cystectomy may actually be in the best interest for certain patients. Therefore, I argue we must compare pembrolizumab with cystectomy after recurrence with immediate cystectomy to better inform our patients and help guide treatment selection. So another consideration from the trial regards known adverse events associated with pembrolizumab. We can see that 66% of the patients have an adverse event. 13% had grade 3 events. So these are defined as severe and undesirable. And grade 4 events, which are life-threatening or disabling. No patients experienced grade 5 events or fatal events. And 11% had to discontinue treatment due to adverse events. So new therapies are seldom without potential harmful side effects, but to achieve the outcomes reported in this trial, we are putting patients at risk for these severe adverse effects. So we must question, is the risk worth the outcomes achieved? And when discussing adverse events, we must consider if pembrolizumab treatment had a significant effect on quality of life. So this trial used quality of life as an exploratory endpoint. They collected validated fact questionnaires or functional assessment of cancer therapy questionnaires at a predetermined time point at 45 weeks in patients who were responders to treatment. They actually found that the majority of patients' quality of life was not impacted. 70% of responders had improved or stable FACT-G scores from baseline, and 83% had improved FACT-G's physical well-being scores from baseline. And as a potential alternative to pembrolizumab therapy, we know cystectomy is associated with a reduction in quality of life. I argue, though, that for those who experience reductions in quality of life undergoing pembrolizumab therapy, if 81% of patients require additional therapies after failing pembrolizumab and then undergo cystectomy, could we be further reducing quality of life in patients who must undergo both pembrolizumab treatment and cystectomy? So additionally, this isn't to say that the alternatives to pembrolizumab therapy are not without their own potential consequences. We know that undergoing radical cystectomy is associated with significant morbidity and mortality. In a systematic review by Maybaum et al., they reported a 34.9% rate of in-house complications for cystectomy, a 39% complication rate 30 days post-op, and a 58.5% complication rate 90 days post-op. The most common being GI and infectious. And when looking at weighted mortality rate, they found a rate of 2.4% for in-house mortality, 2.1% for 30-day mortality, and 4.7% for 90-day mortality. So cystectomy as a possible curative option is not without its own serious risks. Finally, we must acknowledge the cost and financial burden that pembrolizumab treatment can put on a patient. A full course of pembrolizumab costs approximately $300,000, or $200,000 based off of the average duration of response. Radical cystectomies, on the other hand, cost approximately $53,000. So for patients who opted for pembrolizumab and subsequently required cystectomy, their total costs exceed $250,000 compared to a little over $50,000 if they opted for immediate cystectomy. So in conclusion, pembrolizumab does appear to provide benefit for some patients who refuse radical cystectomy. And other than radical cystectomy, there is currently no accepted standard of care for this population. But a large portion of patients initially treated with pembrolizumab subsequently do undergo cystectomy. Therefore, there is concern for utilizing pembrolizumab in patients who refuse cystectomy, yet are surgical candidates. And without data comparing pembrolizumab use to immediate cystectomy upon recognition of BCG unresponsive status, we cannot adequately determine improved survival. So looking ahead, I argue that future studies should compare pembrolizumab use followed by cystectomy to immediate cystectomy to determine if treatment delay may lead to worse outcomes. I also believe quality of life should be included as an endpoint to determine if quality of life is significantly impacted for those who must undergo pembrolizumab and cystectomy. To finish, I also must note that there is an ongoing phase 3 trial comparing pembrolizumab with BCG compared to BCG monotherapy in patients with high-risk non-muscle invasive bladder cancer that is either persistent or recurrent following adequate BCG induction therapy, or that is naive to BCG therapy. The hypothesis being that the combination of pembrolizumab plus BCG has a superior complete response rate compared to BCG alone in participants with carcinoma in situ. So I'd like to thank all of you for your time. We can now open the floor to discussion. Thank you.
Iain, that was a great review. I loved your take on the literature, and in part because I agree with everything that you said. So Pembro is insanely expensive, and the study design was terrible. I think one thing that's important to know is that, you know, cohort A and cohort B in that Keynote trial, as you said, you know, one includes CIS and one does not. There was a patient death in cohort B due to treatment-related colitis. And so I think, you know, when I talk to patients about Pembro, I tell them that it's very unlikely that they're going to have a durable response. They're most likely going to still need cystectomy, and that 90+% of patients who are candidates but are just trying to avoid cystectomy, most of them don't do it. It's a rare patient that we treat with Pembro.
Mm-hmm. That makes a lot of sense. Thank you for including that.
Yeah. I saw Joseph Kim on the line. I don't know if he still is. Dr. Kim, are you there? Nope. All right. A couple of similar drugs, atezolizumab, durvalumab, have had their indications withdrawn in the past few months for urothelial for metastatic urothelial cancer that was previously treated with platinum, and it's because of delayed follow-up. You know, a longer follow-up showed no impact on overall survival. Do you think that when we look at, you know, recurrence within a year, are we looking at the right outcome for Pembro here? Or is there a more meaningful outcome we should be looking at?
So I agree that it could be a meaningful outcome. I think overall survival, median, and then progression-free survival. These have been included in drugs, similar drugs that are going through FDA approval. I think they could be potentially a better outcome, and we could extend the timeline that we look at them as well in past just 12 months. So I think with this data as well, it would be interesting to look at long-term follow-up past the 36 months that they included to see if their interventions change the outcomes for these patients.
Yeah, Ian, I mean, this is Michael Lehman. I completely agree. If you think about it, it's sort of shocking that such an early endpoint is used to lead to the approval, because it's meaningless, right? I mean, if the intention of the drug is to really, what we're giving it for is to avoid cystectomy, it seems that the outcome you need to use is some long period of 5-year cystectomy-free survival or something like that. So to use something that's so proximate is, it's nice to see there is a local response, but it doesn't tell you the whole story. And I don't think that's why patients are signing up for the drug. They're looking at it because they think they're going to keep their bladders for the rest of their life, or at least for a meaningfully long period of time. But a year or two is probably not that meaningful.
Right, I completely agree.
So there was a paper published in the Journal of Urology within the past week or so. Also Ashish Kamat, but MD Anderson, looking at their BCG in high-risk disease, looking at efficacy of BCG in the modern era, and really impressive data that looks far different than the older literature does, with 5-year freedom from progression greater than 90%, and 5-year recurrence-free survivals of about 75% for people in the traditional high-risk non-muscle invasive bladder cancer category. And I think that really is going to call into question whether or not we should be doing a trial like Pembro plus BCG early on, right? Because BCG itself is already so effective, and that's not a trial I would actually subject one of my patients to. I just don't think I could do it. What are your thoughts about that?
I agree. I think we have to weigh the, with all of the new drugs that are being studied for this patient population, we really do have to weigh the risks and the benefits of subjecting these patients to treatments which potentially have marginal benefits, but also take into account that recent data published that patients could provide benefit have benefit without them, and we just really have to educate our patients of their best treatment options, and really provide all of the information required to best inform them.
Yeah, that's a very nice job.